Hi, I'm Helen Bauer, and this is the Heart of Hospice podcast. The Heart of Hospice podcast is your source for compassionate and informative discussions about hospice and end-of-life care. I'm a certified hospice and palliative care nurse with over 15 years of experience. Whether you're a caregiver, someone with a serious illness, or you simply need to know more about hospice care, this podcast is for you. Join me as we explore all the aspects of hospice, from the details of caregiving to the emotional and spiritual dimensions of end-of-life journeys. For more resources and to connect with me, visit theheartofhospice.com and find us on Facebook, Instagram, and LinkedIn. Keep listening for today's episode.
This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
This episode is sponsored by Hospice Navigation Services. When you need information about hospice, Hospice Navigation Services is here to help. An expert navigator will answer your questions about end-of-life care and give you the tools to feel confident in your decisions. A hospice navigation session is a great way to troubleshoot your current hospice care. It's your journey. We can be your guide. Visit hospicenavigation.com to schedule your hospice navigation session today.
We're getting back to the basics of hospice care today, talking about dementia-specific directives with hospice social worker Rosie Gaston. My friend Rosie Gaston is back on the show again. She has over a decade of experience supporting individuals, families, and professionals through the intricacies of end-of-life care. She got her start as a hospice volunteer. Now she holds a Master of Social Work degree. She speaks on local and national levels, and she's also promoting the field through research. In 2022, Rosie founded A Better Ending. It's her way of focusing on community education and fostering professional development in the end-of-life space. At the same time, she continues to work part-time as a hospice social worker. Rosie is also serving as an adjunct professor at the University of Minnesota Master of Social Work program, and she's a board member for the Minnesota Network of Hospice and Palliative Care. The network is an organization that provides resources and support not only for hospice providers, but for hospice patients and family caregivers as well. So you can find all the resources that the network has to offer at MNHPC. And remember, you can always go into the show notes to find the link to that website. And if you want to connect with Rosie Gaston and see the work and support that she provides, you can access that at abetterending.org. In today's episode, Rosie and I discuss how a person's denial of an issue surrounding a terminal diagnosis or prognosis can create a challenge to creating an advanced care plan. Makes sense. Rosie encourages people not to try to think through every possible scenario because that's really not realistic. You can't predict every scenario, but it's better to consider the levels of care that might need to be considered and discussed. And she offers some resources to help you do that. Rosie also talked with me about making promises as a caregiver or as a person with a serious illness, asking for promises, and how promises basically should be avoided. Circumstances can change, and that may require something different where the choices are very limited. Rosie also explained something to me called the Ulysses Clause and how it can be used in an advance directive, particularly with VSED, voluntarily stopping eating and drinking. This is a great conversation. Stay connected with me. Stay connected with Rosie. She's an amazing guest. Find her at abetterending.org and check out the Minnesota Network of Hospice and Palliative Care at mnhpc.com. We hope you stick with us till the end of this episode. There's a lot to learn. Rosie, welcome back to the podcast.
Thank you.
It's great to have you back. We're doing another Back to Basics episode, so we are going to jump in to our topic is dementia-specific directives. We're going to dive into the details of this because I think it's a really valuable conversations. And one of the reasons we chose this topic is because the largest and fastest group diagnoses of Medicare hospice patients in the U.S. is the neurodegenerative diseases, Alzheimer's, dementias, and Parkinson's.
Yep.
So we felt like this is a good one to do. There's going to be plenty to talk about. Let's put it that way.
Yeah, I mean, I think the last statistic I saw was like 2023 or 2024, and it was 6.7 million Americans over the age of 65 have, and this isn't even all the dementias, this is specifically just Alzheimer's.
Yes.
Right? So if we pull in all the other dementias as well, too, that number is going to be exponentially higher.
Yeah. This is our biggest group. It used to be when the hospice benefit was established back in the 80s, mid-80s or so, cancer was our biggest diagnosis. It was the majority of our patients, over half. And that's not the case anymore. Other diagnoses have taken that over. So we're going to focus on dementia directives today because it's a big deal.
Yeah.
And dementia can be a really slow roll, a long disease trajectory that takes a long time for so many people.
Yep.
Things change, patients change, their ability to make decisions change, and there are folks who anticipate having end-stage dementias.
Mm-hmm.
Maybe not as a primary terminal diagnosis, the primary diagnosis, but maybe as a secondary condition, a comorbidity. So it's really something worth talking about. So we're going to start out. When should you be doing a dementia advance directive? Under what circumstances would that be a good plan?
I mean, my thought is there should be some consideration of the questions that are on these dementia-specific directives for anyone who's aging.
Mm-hmm.
Because you think about it, most of the time, at least some of my experience has been supporting folks who start to get cognitive impairment. You have some people who are saying, hey, I'm noticing this change in myself. I want to go see a neurologist. I want to go see a specialist.
Yeah.
And then you have some people who don't want to go there. And whether it's feeling some sort of shame or understandably a sense of denial because accepting this is just so terrifying for them, right? We have to be understanding that denial is a protective mechanism, right? That people put into play to protect themselves. And then they start overcompensating, to hide some of these symptoms that they're having. And then they get a much later diagnosis, and then engaging in some of these really in-depth questions surrounding their values and what their goals are for their healthcare can be really tough for them. Yeah. So honestly, I would encourage some of this reflection even before you get a diagnosis of mild cognitive impairment, but then especially once you're starting to see some of these, whether it be memory issues or impulsivity, some of these behavioral issues, some things that might indicate cognitive impairment, then that just puts an extra gasoline to the fire of the necessity to really sit down and do this ASAP.
Yeah, absolutely. So earlier on is always going to be better to have these conversations.
Yes.
So pretty much everybody is who we recommend doing this. If you're doing an advanced care plan that's comprehensive, it should be included if you're doing all that conversation anyway. Right? If you're doing all the reflection and then the documentation. So the timing of signing these directives is really important because people who are in the later stages should not be and cannot be signing these forms. They can't understand them. It's not a legal form. It's invalid. I have seen hospice agencies that unfortunately had folks with end-stage Alzheimer's or dementia actually sign their own election forms, which is illegal. It's fraudulent, it's invalid, it's unethical, you name it. It can't be done. So the timing of discussing these things is important. I want to touch really quick on something that you said about denial. I had a guest on that talked about denial as a coping mechanism. So if you take that away from somebody, you have to give them something else to hold on to. If you pop the bubble, then they have nothing to hold on to. There's actually, it's robbing them of some hope.
So when I think about supporting folks who I'm seeing are expressing denial, right? We're seeing that this is how they're coping to get through this. I always view this as I can't bulldoze through that wall of denial because it'll make their entire foundation crumble.
Exactly.
Right? Our defense mechanisms, if we even take this a little bit further back, are usually established when we're kiddos. It's what we learned from the caregivers that are around us. So usually our defense mechanisms tend to mirror those who had a big part in raising us. And so for how long denial, whether it's denial, avoidance, suppression, whatever it may be, it's usually things we learned when we were kids that have been in place to help protect us and carry us through. So if I'm supporting somebody who is struggling to accept that they have this new diagnosis, that they have a terminal diagnosis, I'm not going to bulldoze through and say, well, you need to accept this.
Right. This is the reality of the situation.
Well, it's going to be going in very gently and expressing a lot of empathy and normalizing how hard this whole situation is, and then slowly engaging bit by bit in ways that and reassurance that I'm here to help you. I'm here to walk alongside you. So even when that fear comes up, if you have some good rapport with this individual, they're going to feel sometimes a sense of security in knowing that, well, I do have this person alongside me to help guide me and to help be there to support me, or leaning out to people within their own personal supports. Sometimes as a clinical social worker, it's what other coping skills can I bring in as well that's worked effectively for you in the past, as you're also facing some of this. Yeah. So I just have very strong feelings about us using denial as a negative label compared to seeing denial and having an extra layer of compassion and empathy, understanding that they're doing the best that they can, and having it be an indicator for us on how we can best support that person.
Yeah, I think we have used it as a derogatory term. They're in denial. What that really is truly is a coping mechanism based on years of habits and behaviors and family culture and all. And it's amazing when you start looking at the depth of it. So that complicates the care and the treatment. Mm-hmm. These coping mechanisms, the denial, whatever you want to call it, dementias also complicate care and treatment. That's one of the reasons the conversations early on are so important. Because so say you've got somebody with end-stage cardiac disease, right? Okay. They've got bad heart issues, shortness of breath, et cetera, et cetera. If there's mild to moderate dementia that's progressing, man, it makes a heart cath so difficult.
Yeah.
Yeah. Even somebody with compromised mobility and balance, if they have congestive heart failure and you need to weigh them every day, which is something, that's super simple. You would expect that to be done at home, not a big deal. But if they have cognitive and balance, physical mobility issues, their messages aren't getting to the muscles the way they should, even something as simple as weighing. Yeah, becomes an impossibility.
Or, I see this a lot with folks who will have a really bad fall. And then, they have advanced dementia and they go into the hospital. And one of the docs I work with, this is hands down his pet peeve, because then ortho gets involved and immediately they see something that they can fix without looking at the overall picture.
Right.
And then they go through this surgery, which can have, a painful healing process that requires them to do some exercises. But you're asking somebody with advanced dementia to engage in activity that causes them pain. And they can't grapple or understand. No, it's just, no, I don't want to do this. Right? I think one of the blessed, getting it back to like the dementia specific directives, this is a factor of these directives that's so helpful, is because these directives really ask folks to consider their level of functionality or the progression of their disease when it comes to making decisions, right? So, there's a few of my favorite healthcare directives out there that are dementia specific. One is it's the Advanced Directive for Dementia by Dr. Castor from the University of Washington. This one is super simple. It's 3 pages, and essentially the one page says if you have mild dementia and outlines what that looks like. Would you want all care done possible to extend your life? Would you want some care done? Maybe go to the hospital to fix things that can be fixable, but I wouldn't want to go into an ICU. And then that bottom bucket is I really would just want to focus on comfort care. Right. Then the second page is if I had moderate stages of dementia, then really spells out what that is. And then that third page is if I had advanced dementia, what would I want? So, this is a really simple directive that can just help people think of, instead of thinking about every single possible treatment or illness that could come the way, it really simplifies it, that if I was at this stage of functionality, you've heard me, Helen, say numerous times, the line in the sand. Right? If this is where my level of functioning is, at this point, is that quality of life for me? Would I want all treatments to extend my life, or then would I want to focus on more comfort-focused treatments?
I think this kind of conversation is so important for the caregiver or the decision maker, because those are some heart-wrenching decisions. Repairing a fractured hip. Yeah. For someone who already has horribly impaired mobility and doesn't know the family members. Treating an infection, which is something we do often with Alzheimer's and dementia patients in hospice. However, they can choose not to do that. Yeah. Aspiration pneumonia, they can choose not to treat that. If I'm bedbound, if I no longer know my loved ones, if I'm unable to interact with other people. The priority that you mentioned was connection for you, was being connected. If I don't have a connection to other people, do not treat an infection. Do not give me nutritional supplements like Ensure and Glucerna and Boost. Yep. Yeah, those directives can include some of these details like this, but I think I love the way this one you're talking about says this is, if it's mild, this is what I want. If it's moderate, this is what I want. I think that's very useful to people because you cannot envision all the scenarios. What if I become physically belligerent with my family at home? And I want to talk about this one because this is a huge thing. We always counsel people not to make promises they can't keep. I will never put you anywhere. I will always keep you at home. That's not necessarily a realistic promise or expectation to create.
Yeah. I also think on the flip side of that, it's important for those who are creating their healthcare directives not to ask their loved ones to make promises like that they won't be able to keep.
Right.
I have supported some caregivers who I am telling you have run themselves into the ground. And literally every single capacity you can think of, their healthcare is compromised. Their mental health has been compromised.
Finances.
Their finances, their social support, the friendships that they used to pour into, they now can't pour into. And so many times when I brought it back, they said, I promised my parent, I promised my spouse that I would never do this to them. And it's like, but look how this is compromising you. Do you think this is what they would want? So I think on both sides, it's important that us as family members aren't making promises that we're not sure we can keep. And I think it's important for the individual as well who's creating these directives to not put their loved ones in positions. And again, that guilt, I think that's a word that keeps coming up to me, Helen, as I'm thinking about this, is then the tremendous amount of guilt that caregiver feels because they feel like they broke this promise.
Yeah. Such a hard thing to live with. And we really want our caregivers to come through this whole experience and at the end of the day have no regrets or very few.
Yeah.
Very few. But relocating your loved one after saying, I will never do this.
Mm-hmm.
Yeah, that's a big one. That is a big one in my experience.
And these are some of the pieces that these dementia directives specifically bring in as well, too. So most of the time, these dementia directives are something that are added to a healthcare directive you already have.
Right. It's part of a bigger package.
Yes. So this is, somebody could do, a basic healthcare directive with their attorney, and then, a few years later are saying, I think I want to add this specific dementia directive. So I have this just for additional context. And it lists things like you've already mentioned, talking about antibiotics. This is such a huge one that people don't even think twice about so many times. Of a pneumonia even comes up in hospice and immediately we're like, well, let's get some antibiotics going. It's like, let's pump the brakes here and let's look at either a healthcare directive if we have one, or let's talk with the family and educate about what a death could look like if we don't treat it with antibiotics. And if mom were here right now, dad were here right now, they were a fly on the wall, able to chime in about what it is that they would want. What do you think they would say at this crossroad? Many times that's what I encourage when there isn't a healthcare directive or the healthcare directive is too vague, is I say if your loved one, say 15, 20 years ago, was sitting here with us right now, this chair was pulled up and they were hearing this conversation, what do you think they would say? Because it can be helpful to get that person out of their head of what they want for their loved one versus really what would they say in this circumstance. But these directives also pull in, where would you want to live? How would you, what kind of care would you want to receive? Of course, like most healthcare directives touching on CPR,
Right.
but also sometimes these distressing, the language we often use in the healthcare space is behaviors. Oftentimes I really view them as responses or reactions. Usually there's something that triggers, a quote unquote behavior. But when you think about that, if people are getting really angry, sometimes they can get violent.
Yes.
The kindest, I just cared for a woman last week, and how her family described her was essentially an angel on earth. And then as her dementia progressed, she is angry.
Yeah. She changed.
Yeah. And she is, she's being aggressive towards staff and towards people trying to care for her. And so even when we think back, with these directives, if I have these, we'll just again use the language, these distressing behaviors, first off, is there something we can do that's non-pharmacological that could help?
Right.
So I think of if my mom or dad, get in a position where they have an advanced dementia. My parents are both professional musicians. I'm going to have specific songs, specific albums that I want their team to play for them to try that first. But if that's not happening quickly, are we okay with bringing on medications like Haldol or like lorazepam to help with some of these distressing behaviors? So again, that's the beauty of these specific directives, is they pull in circumstances or situations that are more common with this specific disease.
Right. Right. And I think we all need a little bit of help, especially if you are not a healthcare worker in any capacity.
Yeah.
You may not have any concept of what it's going to look like when it gets to middle and later stages. I hope you're enjoying this episode. We're going to pause for just a minute. My guest has more to share.
This episode is sponsored by Hospice Navigation Services.
If you or someone you care about is dealing with a life-limiting illness, you need a guide. Hospice Navigation Services is here to help you get the best end-of-life care possible. We understand the importance of personalized, experienced support. Hospice navigators provide one-on-one support over the phone or through video calls to guide you every step of the way. They'll answer your questions, explain what hospice care looks like, and give you the tools to feel confident in your decisions. Whether you're planning ahead or you have an urgent need, Hospice Navigation Services helps you and your family understand your options for end-of-life care. A hospice navigation session is a great way to troubleshoot your current hospice care and get answers to your questions. You don't have to go through this alone. You deserve compassionate support and guidance for your end-of-life experience. Hospice Navigation Services can be your guide. To book your hospice navigation session and receive your free guide to end-of-life care, visit our website at hospicenavigation.com. It's your journey. Hospice Navigation Services can be your guide. You taught me one time about a Ulysses clause, and I want you to teach about that. Reteach me and teach my listeners, what is a Ulysses clause and when is it used?
Okay, so a Ulysses clause is essentially saying, I want you to listen to the person who created this healthcare directive and not to my future self who no longer has decision-making capacity.
Got it.
So where I've commonly seen Ulysses clauses is in dementias that are specifically talking about voluntarily stopping eating and drinking. The acronym we use for that is VSED. So, if you are an individual who's thinking about and planning for a dementia journey and you say, if I get to the point that I can no longer, again, we have to be specific. This is the thing about these dementia directives, is when you can say, when I can no longer recognize who my wife is on a consistent basis, I want to initiate voluntarily stopping and eating and drinking. And so, and there's some healthcare systems that will honor this. There's some that really, really still struggle with this. I'll be transparent with you. VSED is viewed as something that is legal and ethical, but when we bring in a lack of capacity to it, it just does make it more complicated. So I very much want to echo that. I've had folks who have lived in a skilled nursing facility who had this in their healthcare directive, but because they're living in a skilled nursing facility, and they no longer have capacity. And now the patient is saying, this is bringing it back to Ulysses clause, but I'm hungry.
Right.
I want something to eat. Right. What the Ulysses clause is saying is don't listen to myself with dementia who's saying, I want food. I want you to listen to the person who wrote this, who had full capacity and is saying, when I get to this state of my functionality, this is what I want for my care, despite what I may say in that current state.
But it's so hard to discern. It does, but it is very hard to discern. Is this a person with dementia and this is reflexive speaking? Because you can have someone with advanced dementia and you say, how are you feeling? Fine. It's a reflexive response that they've had their entire life.
For sure.
Right? So it's not necessarily indicative of their status. So for a person with an advanced dementia to say, I'm hungry, is that reflexive or is it really indicative of the fact that they're hungry and they have an empty tummy?
Yeah, for sure. I mean, even when we think about that reflective response, another could be a reflective behavior. So I think about some of the folks when I'm in memory care settings and I will see that they are being, assisted hand feeding. So essentially what this means is a staff member is feeding them their meal.
Right.
And it's almost, there's a dietitian I worked with, this is not my language, it's hers, but she called it the birdie complex.
The birdie complex.
You bring food to the mouth. It's a reaction. It's a reflex. I mean, you think about when we're babies, our parents did the airplane getting the food in our mouth. If we were parents.
You touch the spoon to the mouth and they open. Yes.
Yeah. And so there's been many loved ones I've cared for who say, because again, something we see sometimes in hospice is folks continue to open their mouth, they gain weight, now they no longer qualify for hospice.
Right.
And I've had loved ones ask me, do you think they're actually even hungry or are they just eating it because it's being provided to them? So this is another thing that can be in your healthcare directive is if I'm no longer able to feed myself, if I'm no longer able to bring that spoon to my mouth, I do not want assisted hand feeding.
Yes. But so hard for a family to try to make a decision like that. That's when the directive becomes vital.
Yeah.
Yeah.
And I will say one of the most ethical end-of-life issues I have seen in my career time and time again, almost always revolves around feeding and eating.
Yeah. That's a big topic.
It's our culture. It's how we show love. It's how we connect with each other. And it's hard for folks to understand that a dying body has different needs than a body that's trying to sustain life.
Yes. Even people with end-stage dementias and Alzheimer's can eat and yet lose weight.
Yeah.
Yeah.
So that's why it's so important to just be so specific about this.
Yeah.
I want to just provide some resources for your listeners too. Another healthcare directive is End of Life Choices New York. They actually have a specific dementia diagnosis. They also have one related to voluntarily stopping eating and drinking. And I will say this one is very detailed. So if you're working with somebody who's already pretty overwhelmed, this is not one I would gravitate towards.
Okay.
But for folks who really want to get into the nitty-gritty details, I mean, they even go so far to look at this balance of safety and autonomy, of looking at, from driving to firearms to current sexual partners to future sexual partners. So it's not even just about like your medical decisions, but this is about your lifestyle choices and how they can best support them as your disease progresses as well too.
Tell me again where this one can be found.
Yeah, so if you even just put into Google End of Life Choices New York Dementia Advanced Directive, it's going to pop right up.
Okay, I'm going to have a link to it in the show notes so our listeners can go in and find it, because of course we want you to have the resources and the information, but we also want you to be able to download something free if that's available. That's available, and it looks like it is.
Yeah, a few other resources, because you wouldn't have a social worker on the show if we're not pumping out resources, right?
That's their job. Let's go.
So End of Life Choices New York, again, this is the one that if I were to sit down with my loved ones, because I want details, vague directives do not help. We need specific, right? This is very specific, but again, with caution, if you're a clinician working with somebody who's navigating denial and struggling to look at this really face on in that detail, that might be a bit too much. The Advanced Directive of Dementia, the one I mentioned previously with Dr. Gaster from the University of Washington, this one is much more simple.
Okay.
And then a nice one that's kind of a nice in-between is Compassion and Choices has a Dementia Values and Priorities tool.
Okay.
And they have this is actually available in Spanish and in Chinese as well.
Okay.
And then the last resource I want to bring to light is I talk about the Conversation Project all the time. They are one of my favorite resources. And while they don't have a dementia-specific diagnosis, they have a really helpful handout for, loved ones, families, caregivers who are wanting to have these conversations but need some support and just kind of some basic guidance on how to do that.
Yes. Well, I will have links to all of the websites in the show notes. So if you're listening and you're interested in these resources that Rosie's brought up, you'll be able to go into the show notes and find all of them. Very important resources to be able to get your hands on and then decide what's better for you. Do you need one that's more generic and general? Are you looking for something super specific? Or do you just need some guidance on having the conversations with somebody in the early stages, mid stages? So super important. Rosie, where can listeners find you and the work you're doing?
So you can go to my website, www.abetterending.org. I do a lot of speaking and education surrounding advanced care planning, end of life, ethics, and even, how we can live more fully now based on what I've learned at the bedside as well, too. So whether that be in community settings or professional development settings, I love being in that space and bringing this conversation forward. And then if you're here in Minnesota, one of the primary ways I support folks here in Minnesota is by creating these really thorough and detailed healthcare directives or advanced care planning documents. But it's also, I help people have the conversations. So for loved ones who are saying, I know we need to do this, but man, I don't know what language to feel forward. I'm feeling some anxiety about that. People can give me a call and I go into the home and help navigate those conversations.
Wonderful. Tell me the website one more time.
www.abetterending.org.
Abetterending.org. Rosie, I love having you on the show. I hope you be back soon.
Oh, anytime. You just let me know.
Thanks for listening to the Heart of Hospice podcast. Check out our sponsor in the show notes and please leave a rating and review on Apple Podcasts. We would appreciate it if you would share this episode with your friends and family and anyone who needs to know more about hospice. Connect with us on Facebook, Instagram, and LinkedIn. And remember, no matter who you are, or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.